बस वेट करते हैं 5 मिनट. Hello, am I audible? My video and my screen, they're visible, right? Just put a thumbs up button if it's visible, my screen, my video, and I'm audible. We'll start in 2 minutes, okay? Guys, we'll start in 2 minutes. By 4 or 5, we'll start. Okay, let's start. Okay, so today we'll cover very small topics of gynecology, and we'll cover like 2 or 3 most important topics, which include infertility. We'll try to cover endometriosis, okay, and cancers. So let's start with some easy topics of gynecology. Okay, so we'll start with menarche. Okay, this is very basic thing, and we all should be knowing this thing. Okay, so what is menarche? This is the onset of menstrual cycles in females, right? So whenever a female in the female's life, whenever they like the starting of menstrual cycles, we call it menarche. Okay, so menarche usually occurs after some secondary sexual characters. Okay, so what are these secondary sexual characters? They are thalak, pubic. Okay, so let's imagine this thing. Let's say there's a female of there's a girl, okay, 8-year-old girl, okay, and now she has no sexual characters, okay, and there's no menstruation. Okay, so we are talking about a pre-pubertal girl. Okay, so what are the changes which happens in pre-pubertal girl is, so around at age of 10 to 13 years there will be some secondary sexual characters appear in the female sexual characters. And what are these secondary sexual characters? We call it thalarch. So thalarch is the first secondary sexual characters which appear in any female. Okay, thalarch is breast enlargement. Then there will be pubarch. Okay, so arc means like there's this starting of something. Okay, so pubarch, like there's appearance of pubic hairs. And then comes menarche. Okay, now you understand why we call it menarche, because this is the starting of menstrual cycles. Okay, so all of us, we know about menarche. So why am I talking about menarche? Is to cover these things which are known as precocious puberty. Okay, there's early puberty, there's delayed puberty. So I've started the topic of menarche to explain these three things. See, in the Krok question, they have already asked about precocious puberty. Okay, so they have already asked what is precocious puberty. Is any female with menarche before less than 8 years of age. Okay, so if any female girl, okay, she's having menstrual cycles or secondary sexual characters before the age of 8. Okay, we call it precocious puberty. Early puberty, we call these menarche, thalarch, pubarch, they appear at the age of 9 to 10 years. Okay, then we call it early puberty. And delayed puberty is when no menarche appears after 13 years of age. Okay, so see, we were talking about 8-year-old female. Okay, if she develops secondary sexual characters plus menarche, we call it precocious puberty. Okay, so now all of us, we know the meaning of precocious puberty. Okay, in the Krok question, they have specifically asked what is the most common cause of precocious puberty is, and the most common cause for precocious puberty is endocrine disorders. So this endocrine disorder is important for exam. Okay, so they have asked about precocious puberty. They might ask about early puberty or delayed puberty in new question. So early puberty is 9 to 10 years, and delayed puberty is when no menarche more than 13 years of age, but secondary sexual characters are present. Okay, or we can also call delayed puberty if there's no menarche more than 15-year-old girl with presence with if the secondary sexual characters are absent. If secondary sexual characters are present, we can extend the definition till 15 years of age. Okay, so if secondary sexual characters are absent, there's no menarche in a 14-year-old girl, we call it delayed puberty. But if the secondary sexual characters are present, but still there's no menstruation, we can call it delayed puberty, like till the age of 15, after the age of 15 years old. Okay, So menarche. So after menarche, we'll talk about juvenile bleeding. Okay, so juvenile bleeding. So let's say a female has attained menarche. Okay, so whenever she attains menarche, so there will be there will be irregular menses. There will be anovulatory cycles, and there will be painless cycles. Okay, there will be irregular menses, painless cycles, anovulatory. There can be disturbed menstrual cycles. Okay, we call it juvenile bleeding. Okay, why juvenile bleeding is, see, whenever a female attains menarche, so there will be irregular menses for around 2 to 5 years. Okay, after menarche, so all the cycles after menarche for 2 to 5 years, they will be irregular and anovulatory cycles. Okay, so that girl won't be able to get pregnant during this period of time, and we call it juvenile bleeding, or this juvenile bleeding, or also known as adolescent bleeding. Adolescent bleeding, right? Okay, so for treatment of juvenile bleeding, we can do some hormone therapy if the patient is worried about her irregular menses. Okay, otherwise some dietary therapy we can prescribe, or CBT, cognition behavioral therapy is enough. If the patient is too much worried about her irregular menses, then we can prescribe hormone therapy. Okay, so let's say if the in our case, in 8-year-old girl, okay, when she became 10, 12, she developed all the secondary sexual characters, then she got menarche. But what if there's no menarche at all till the age of 16, 17? So we call it primary amenorrhea. So what is primary amenorrhea is no menarche from adolescent age. So the female has never attained any menarche. Okay, she has never undergone any menstrual cycle from her like in her complete life. We call it primary amenorrhea. While secondary amenorrhea is, so she attained menarche for few years, and now she has amenorrhea. So let's say a girl has attained menarche at the age of 13 years, and at the age of 21 she is having no menstrual cycles. Okay, we call it secondary amenorrhea because the patient has attained menarche at once, and now there are no menarche, or no menstrual cycles. Okay, we call it secondary amenorrhea. So there are many causes for secondary amenorrhea, and the most common cause is pregnancy. Okay, like this is not a disease, right? This is not any abnormal situation, but pregnancy causes amenorrhea for almost 10, 15, 20 months, because after pregnancy we also get lactation, right? So in pregnancy there are no menstrual cycles for 9 months at least, right? This is also amenorrhea, but this is secondary. In lactation period, for around 6 months, we don't get any menstrual cycles in females, right? We call it lactational amenorrhea. We talked about it yesterday. So these are like physiological condition. These are physiological, not pathological, right? Okay, but what are the pathological causes for secondary amenorrhea? What are the pathological causes? So we get questions for pathological causes for secondary amenorrhea, and yesterday we talked about Sheehan syndrome. Okay, Sheehan syndrome is one of the most famous cause of secondary amenorrhea. Okay, and for Krok question, the Sheehan syndrome is very important, right? Apart from Sheehan syndrome, we have some endocrine disorders also, another endocrine disorders which causes secondary amenorrhea. Among them, Cushing syndrome, Right, so I'll explain why in Cushing syndrome we get secondary amenorrhea, hypothyroidism, we get secondary amenorrhea. We can get secondary amenorrhea in PCOS also, right? So these are the main causes of secondary amenorrhea. In prolactinoma also we can get. So I'll explain all of these one by one, but just I'm making a list for all the causes of secondary amenorrhea, pathological causes. Pregnancy and lactation also causes secondary amenorrhea, but they are physiological. So we'll talk about pathological causes of secondary amenorrhea in depth. Okay, Sheehan syndrome. We talked about Sheehan syndrome yesterday. Okay, so let's start with some endocrine disorders which can cause secondary amenorrhea. Okay, let's start with Cushing syndrome. Okay, so with gynec, I'll try to cover some of the topics from endocrine also. Okay, so like this hypothyroidism and Cushing syndrome. So we all know in Cushing syndromes we get more cortisol. Okay, and all the symptoms because of this increased cortisol. There's blue striae on abdomen, then there's hypertension, there's centripetal obesity. So there are a lot of symptoms from Cushing syndrome, and one of the important symptom which we are worried about, amenorrhea. Okay, so why do we get amenorrhea in case of Cushing syndrome? Okay, so in Cushing syndrome, this increased cortisol causes decrease of gonadotropin releasing hormone. If GnRH is decreased, there will be decreased FSH and there will be reduced LH. If all the sex hormones will be reduced in this female of Cushing syndrome, it will cause to amenorrhea, and all these hormones they are reduced because of cortisol. Okay, so in Cushing syndrome, that's why we get amenorrhea. Okay, what other signs we can get because of this decreased sex hormones is there will be hypoplasia of uterus. If there will be decreased follicular stimulating hormone, there will be hypoplasia of ovary. Right, so these are the main signs and symptoms of Cushing syndrome, and for gynec our main thing is amenorrhea. Okay, and now we know the reason why do we get amenorrhea in case of Cushing syndrome. Because of increased cortisol, there will be decreased GnRH, decreased FSH, decreased LH, and if there will be no sex hormone in the female, so there will be no menses. Okay, this is understandable. Then in case of hypothyroidism, also we get amenorrhea. Okay, what other sign and symptoms of hypothyroidism are? There will be cold intolerance. There will be increased body weight. Okay, there will be bradycardia in the patient. There will be somnolescence. What is somnolescence? There's increased sleep. Okay, increased sleepiness. There can be chills and edema. Okay, so I'll quickly cover amenorrhea. Okay, I'll explain why in hypothyroidism we get amenorrhea. This is very good concept. Okay, see, in hypothyroidism, this is understandable that we have decreased T3, T4. Okay, and with this T3, D4 decreased, there's increased TSH. We call it primary hypothyroidism. Okay. Then if this T3, T4 reduced and there's decreased TSH also, we call it secondary hypothyroidism, because there's some problem with pituitary gland. hypothyroidism. Okay, this all we know, right? The important thing is, I'll make here. So there's this hypothalamus. Okay, this hypothalamus releases thyrotropin releasing hormone. There's anterior pituitary. Okay, it releases TSH, and then it stimulates thyroid gland, and then thyroid gland releases T3 T4, right? This is very basics. Okay, if in case of primary hypothyroidism, so I'm talking about primary hypothyroidism, there will be decreased T3, decreased T4, but there will be no negative feedback, right? So there will be increased TSH, we know, and there will increase TRH also, thyrotropin releasing hormone. Now I'll explain why we get amenorrhea in case of hypothyroidism. Is there will be decreased T3, T4, increased TSH, and increased TRH. Okay, so whenever there will be increased TRH, okay, thyrotropin releasing hormone. Okay, so what thyrotropin releasing hormone does is it increases the level of TSH and it also increases the level of prolactin. Okay, and prolactin, it inhibits the level of GnRH. So if there will be decreased GnRH, there will be decreased FSH and LH. So in case of hypothyroidism also we can get these endocrine disorder because of amenorrhea. This amenorrhea we can get because of hyperprolactinemia. Okay, so these all signs and symptoms are because of hypothyroidism, because of these all signs and symptoms because of hypothyroidism, right? Because of these things. Okay, and because of decreased GnRH, decreased FSH, decreased LH, we are getting amenorrhea, right? And because of prolactin increase, we will get milk secretion from breasts, okay, in the female. So hypothyroidism can also cause hyperprolactinemia. Okay, so we have talked about Cushing syndrome, hypothyroidism, right? Let's come with prolactinoma. Prolactinoma. See, so from the word oma, so we must have made a mindset, right? We have a mind like this is definitely going to be a tumor. Okay, so what prolactinoma is? It is a pituitary tumor. Prolactin is secreted from pituitary gland. Okay, it is a pituitary tumor and it is functional. Okay, so prolactinoma is a functional pituitary tumor which secretes prolactin. Okay, so in the blood prolactin levels will be far high, and normally prolactin levels are very less in the female when she is not in the period of lactation, right? So there will be no prolactin or very less prolactin, so there will be no milk secretion. If there's a pituitary hyperplasia or there's pituitary tumor and it starts to secrete prolactin, so we will call this condition as prolactinoma. So what will be the clinical presentation of the female? The female will complaints of milk discharge from mammary glands in absence of pregnancy. So she is not pregnant, she is not in the lactation period, and still she is getting milk discharge from breasts. Okay, we usually do the serum prolactin levels for diagnosis. For investigation, we do serum prolactin levels. Okay, if serum prolactin levels are very high, we can order MRI brain to check for pituitary tumor, and we also check thyroid hormone levels. Okay, so now we have understood there are two things which can cause increased prolactin level. One is pituitary tumor and another one is thyroid hormones. Okay, so we'll do thyroid hormone levels. Okay, so what will be the treatment in for treatment in case of pituitary tumor or prolactinoma? So for treatment of prolactinoma we use dopamine agonists. I'll tell you why we use dopamine agonists, but firstly I'll tell you the name of the drugs. Okay, for dopamine agonists, we have two drugs important: bromocriptine and cabergoline. Okay, so in the Krok question, they gave a patient of prolactinoma. So they've given all the signs of like patient is complaining of milk discharge from mammary glands. They are high prolactin level. So we must suspect prolactinoma first of all. Okay, now they directly asked the treatment. Okay, and the treatment was D2 agonist. So we use dopamine agonist. Okay, I'll tell you why do we use dopamine agonist is dopamine inhibits prolactin release from pituitary. Okay, that's why we use dopamine agonists. Okay, apart from this milk discharge from mammary glands, what all features can we get? Okay, so I told you in prolactinoma. So you can make all the signs and symptoms by yourself if you know what endocrine, like what hormones are increasing, what hormones are decreasing, right? So in prolactinoma, there will be increased prolactin. So I told you there will be milk discharge, right? So here hormonal change and causing symptoms, sign and symptoms here. There will be milk discharge from breasts, right? So if there will be increased prolactin, there will be decreased GnRH, decreased LH, decreased FSH. Okay, because prolactin inhibits GnRH release. Okay, prolactin inhibits GnRH release. Understandable, right? So this GnRH decreased will cause amenorrhea. So in case of prolactinoma, we will also get amenorrhea. That's why we were talking about prolactinoma here. Okay, we were discussing the topic of secondary amenorrhea, and there we had this prolactinoma as one of the cause. Okay, and apart from this prolactinoma, so increased prolactin, so it is a pituitary tumor, right? Pituitary tumor. So there will be some mass effect in the brain. So what mass effect? There will be headache, because this is a space occupying lesion, right, in the brain. So it will start compressing other brain structures. So there will be optic nerves going beneath the pituitary gland. So it will compress that, and the patient might complain of vision impairment. So these are the main signs and symptoms for a patient of prolactinoma. So milk discharge, amenorrhea, headache, vision impairment. These are the main symptoms for prolactinoma. And for medical treatment, we have talked about dopamine agonists, bromocriptine and cabergoline. Right. If most of the patients, they usually become asymptomatic with these treatment, and like this treatment works for everyone. Okay, for most of the patients of prolactinoma, but some patients might need surgical management also, surgical treatment also. And for surgical treatment we have to do pituitary surgery, okay, to take out that prolactinoma. So we have to go inside the brain, and then we have to do operate, okay, on this prolactinoma to take out this extra mass. Okay, I hope everyone is clear till here. So we have discussed about prolactinoma, Cushing syndrome, and hypothyroidism. in causes of we were talking about secondary amenorrhea. Okay, then let's start with PCOS. Okay, polycystic ovarian syndrome. Polycystic ovarian syndrome. Okay, so in here they also call it Steen Leventhal syndrome. Leventhal syndrome. Okay, so aka Steen Leventhal syndrome. So we all know like what are the symptoms and what are the signs symptoms we get in the patients of PCOS. Okay, so what will be the clinical presentation of PCOS with? There will be a female, so usually middle aged. So there will be a middle aged female. Okay, middle aged means like from 20 to 30, right? And she will be complaining of irregular menses. Irregular menses. There will be increased body weight, right? So there can be hirsutism. What is hirsutism? Is excess hairs on face mainly. Okay, so patient will complain of hirsutism. She can complain of acne vulgaris. So what is acne vulgaris? Is we get acne on the face, okay, which is the most vulgaris means most common type. So we get acne vulgaris in this patient. We can get insulin resistance in this patient. So insulin resistance will lead to hyperglycemia. So patient can complain of polyuria, polydipsia. Okay, these symptoms can be there. Okay, and it can also cause infertility. So patient might come to your clinic with the complaint of infertility. Okay, so yes. So in case of polycystic ovarian disease, okay, we get clinical presentation of a middle-aged female complaining of irregular menses, hirsutism, increased body weight, acne vulgaris, insulin resistance, excessive hair on the face. Okay, this is hirsutism and infertility. Okay, so why do we get polycystic ovarian syndrome? First of all, so the etiology, I'm not going into depth of the etiology. I'll just tell you one thing, that in polycystic ovarian disease we get multiple cysts, okay, cystic cavities in the ovarian. That means like polycystic ovarian disease, right? And because of this cyst there will be decreased FSH and increased LH in the patient, and there will be increased testosterone in the female. So there's a rise of testosterone in the female. Okay, these are the hormonal changes which we usually get in a female of PCOS. Okay, so because of this rise in testosterone, female is getting hirsutism. This is a masculine feature, right? Hirsutism. Because of this testosterone, female is getting acne vulgaris. Okay, and there's less of FSH, increased LH. Also there are the sex hormone imbalance. That's why female is getting irregular menses. There will be increased body weight, and there will be anovulatory cycles. Anovulatory cycles in the case of PCOS. So how do you know like the patient's cycle, the menses, the menstrual bleed is anovulatory? So there are the main two signs of anovulatory cycle, that is irregular menses, irregular cycles, and painless bleeding, right? So in any normal female you get all the cycles at regular interval, right? And all the cycles, they are painful. So we know that painful regular cycles are ovulatory. Okay, so they are ovulatory. But if they are painless and irregular, we know like this is anovulatory cycles. And one of the most important cause for anovulatory cycle is PCOS. Okay, what other causes for anovulatory cycle can be hypothyroidism, Cushing syndrome, we have talked about it. Sheehan syndrome, like which is a complication after delivery, can also will also cause anovulatory cycles, right? Then, so PCOS. For the diagnosis of PCOS, you do ultrasound, right? So in ultrasound, you will get enlarged ovaries with cystic cavities. So multiple cystic cavities will be there. Multiple cystic cavities will be there. You can do serum LH, serum FSH levels. Okay, serum LH will be increased, FSH will be reduced. Okay, serum testosterone, this will be high. Okay, so so you can make the diagnosis of PCOS on this. To make the cycles regular, you will do hormone replacement. So you will give COCPs, so combined oral contraceptive pills. Oral contraceptive pills. So in these oral contraceptive pills, we usually have estrogen and progesterone combinations. So they will work as a hormone replacement therapy in the females. Okay, so they'll provide all the important hormones which are so there will be decreased estrogen also. So they'll replace those hormones. Okay, so for the treatment of PCOS, we'll give COCPs. In the Krok question, they'll give all these signs and symptoms, and then they'll ask you the diagnosis. So you have to diagnose it as Stephen-Leventhal syndrome or polycystic ovarian syndrome. This hirsutism, all these things. Okay, for patients of PCOS, sometimes they try to confuse you with Cushing syndrome. Okay, in case of PCOS, there's normal blood pressure. Okay, and there's no bluish stretch marks on abdomen, right? And in Cushing syndromes, usually there's hypertension and there's stretch marks, or we called it striacutis. Okay, so don't be confused in Cushing syndrome and PCOS, because Cushing syndrome also we get these symptoms, right? So irregular menses, hirsutism can be there, acne vulgaris can be there, insulin resistance can be there, infertility can be there in cases of Cushing syndrome because of amenorrhea, right? So don't get confused between PCOS and Cushing syndrome. PCOS and Cushing syndrome. Okay, so in Cushing syndrome there will be hypertension also. Understood? So these are the main causes for secondary amenorrhea. One more cause for secondary amenorrhea is anorexia nervosa. So I'll just explain it very quickly because this has never been asked in Krok question. So let's say there was one female, 18-year-old female. Okay, she got her menarche at the age of 13 years. So normal. And now at the age of 18, she is complaining of amenorrhea. So now you have diagnosed the case that this is secondary amenorrhea because patient has already achieved menarche at her at the 13 year of age, right? So she is complaining of amenorrhea. So there are no menstruations at all. Now you on objective examination you find that patient's body weight is too much reduced. Okay, and still she believes, okay, let's say her BMI on objective examination you find out 16, which is very less. Okay, and still she believes that she is overweight. Okay, so this is a psychiatric illness, and we call it anorexia nervosa. What anorexia nervosa is? patient is intentionally not eating anything. Intentionally not eating anything. So she is doing a very strict diet. Okay. And why do we get amenorrhea in case of anorexia nervosa is because there will be less energy and nutrition for all the organ, right? So the pituitary gland will also shrink and there will be less formation of GnRH, less LH, less FSH, because at the time of starvation body will not try to produce all the useless hormones, because reproduction is important in case of healthy female, but in case of malnourished, first thing our body will try to survive. Okay, so survival is the first thing body will use its energy for. Okay, so that's why patient will complain of amenorrhea. Okay, so anorexia nervosa is also important cause of secondary amenorrhea in Western countries. Then move ahead to next topic. So another important topic for our Krok question. So this is the most important topic for Krok 2 exam, okay, in gynecology, endometriosis. Because in every year question we get at least 2 questions from this topic. Okay, so every year we get questions from endometriosis. Okay, so what is endometriosis? See, so endometriosis is a condition where we get endometrial cells, okay, endometrial layer or cells outside uterus. Okay, wait, see, so this is normal uterus. Okay, so in uterus we have inner lining known as endometrium. So let's say we have endometrium here, right? And here we get myometrium, and outside myometrium we have serosa. Okay, so this is the muscle layer. This is myometrium, and this pink color is endometrium, right? If we get these endometrial cells outside from its normal location, we call it endometriosis. I'll give you example. See, if these endometrial cells they are present in ovary by anyhow, I'm not telling you the pathology, like pathophysiology behind it. So if anyhow these endometrial cells they are present in ovary, okay, or anywhere out, let's say in the peritoneum, in cervix, they are not normally present, right? If they are present in vagina they are present, we call it endometriosis. So if they are present in ovary, peritoneum, they can present even in bowel, they can present in vagina, they can present in cervix. So normally they are not present at these sites, right? And if you found some endometrial cells at some different location from its normal location, you call it endometriosis. Okay, if these endometrial cells are present in myometrium, right, so you call them adenomyosis or uterine endometriosis. Okay, so I'll quickly tell you again. So endometriosis is presence of endometrial cells outside uterus, right? Example, they can present in ovary, they can present in peritoneum, they can present in bowel, in vagina, okay, so etc. So if endometrial cells are present at these locations, we call it endometriosis. If it's present in uterine myometrium, if endometrial cells present in myometrium, we call it known as adenomyosis, aka uterine endometriosis. Uterine endometriosis. So you have to learn all these terms, okay? You have to remember all these terms: uterine endometriosis or adenomyosis. Okay, so what will be the clinical features of these cases? Okay, so before starting the clinical features, I'll tell you this endometrial cells, okay? Endometrial cells, they are very sensitive to progesterone, right? They are sensitive to progesterone. And to understand the clinical features, we have to firstly discuss about this normal menstrual cycle. Okay, see, in the normal menstrual cycle, we have for 28 days. Okay, so this is 0 day, this is 14th day, 28th day. And in the normal menstrual cycle, in the initial stage, we have estrogen rise. Okay, and later on we have progesterone rise, right? So during the estrogen period, there's endometrial hyperplasia. Okay, and during the period of progesterone, these endometrial cells, okay, they are filled with fluid like this. Okay, so progesterone causes the endometrial cells to be enlarged. Okay, so they causes enlargement of endometrial cell. So progesterone causes enlargement of endometrial cells. And these enlarged cells, when there's decreased progesterone, so after whenever there's menses, so at the end of 28 days, there's decreased progesterone, and there will be shedding of these endometrial cells. Shedding of endometrial cells. Right. So in case of endometriosis, these endometrial cells are present at some different places like ovary, peritoneum, bowel, vagina. Okay, and they are also sensitive to progesterone. So during this second period of menstrual cycle, there will be increased progesterone. So the cells which are present here, they will also become big and will be secretory, right? And when at the end of this 28th day, when progesterone level will decrease, these will also shed off. This will also shed off, right? So this clinical presentation, so the clinical presentation of the female with endometriosis will be polymenorrhea. There will be dysmenorrhea. There will be chronic pain, and there will be dark bloody discharge, chocolatey discharge from vagina. See, this is the keyword which we usually get in cases of endometriosis in Krok questions. Okay, so for Krok 2 questions, to explain endometriosis, they'll give you this dark bloody discharge or chocolatey discharge from vagina, and this is the case of endometriosis. Okay, what other features can be? There can be menorrhagia and even infertility. In case of ovarian endometriosis, we can get infertility also. Right, so these are the clinical features. We can get polymenorrhea, we can get dysmenorrhea, menorrhagia. Menorrhagia is There's vaginal spotting in between of the cycle. Vaginal spotting between cycle. Okay, there can be these things. Okay, so for diagnosis of endometriosis, right? So let's say you get a patient of adenomyosis or vaginal endometriosis. So technically you have to look for this part, right? So you have to take biopsy of this part. Okay, so you can easily do, in case of vaginal endometriosis, you can do colposcopy and you can take target biopsy. You can take biopsy of these lesion, and then you can, in the path lab, you can study them and find out that okay, these are endometrial cells, they shouldn't be present in vagina, so we call it vaginal endometriosis. So for diagnosis of vaginal endometriosis, you do colposcopy with target biopsy of vagina. So what does target biopsy is? You see some lesions in the vagina, you take biopsy of those lesions. I'll tell you the name of these lesions also. Okay, in case of adenomyosis also you can do curettage of uterus, and you will take out this part of abnormal myometrium, and then you will study and find out okay, these are endometrial cells, they should be present in myometrium, then we call it endometriosis. In case of ovarian, peritoneal endometriosis, okay, these are the main endometriosis outside uterus, we do laparoscopy. And with laparoscopy you will see that there are some lesions which we call it cyanotic eyes, okay, or there's bluish spots. If there's some bluish spots present on the ovary, there's some bluish spots present on the peritoneum, okay, we call it that these are signs, these are suggestive of endometriosis. Okay, so we have we can have an ovarian endometriosis, we can have peritoneal endometriosis, we can have adenomyosis, we can have cervical endometriosis, we can have vaginal endometriosis, right? So if we have endometriosis present at more than one location, we call it disseminated endometriosis. Disseminated endometriosis. Okay, and in Krok they've asked about this disseminated endometriosis. Okay, so the keyword here will be dark bloody chocolatey discharge, and the other one will be on the laparoscopy they can mention is cyanotic eyes, okay, or bluish spots, right? For treatment, they usually don't ask treatment. For treatment you can give COCPs, and for the definitive treatment will be surgery. Definitive treatment will be surgery. Okay. Let's talk about endometrial cancers. Endometrial cancer. So in endometrial cancer is, see, usually when do we get endometrial cancer? Okay, so in case of any cancer patient, age is very important. Okay, because there are some cancers which appears in early age, there are some cancer which appear in middle age, there are some cancer that appears in older age. Okay, so endometrial cancer is one of the senile cancer. Okay, so we see in old age women, old age females. Okay, so usually 55-60-year-old female, they are menopausal. Yes, so usually we get endometrial cancers in menopausal age. Okay, yes, so we get in menopausal females. Okay, So the clinical presentation will be, there will be post-menopausal bleeding in the female. There will be post-menopausal bleeding in the female. Yes, so there will be post-menopausal bleeding. So whenever a female, an old age female, okay, menopausal female, comes to you with complaints of vaginal bleeding, okay, so you should suspect endometrial cancer at first place. Okay, so any female complaining of post-menopausal bleeding, you will suspect endometrial cancer. Okay, so this will be the main complaints. And how do you diagnose? Okay, so for investigation, for investigation, you do diagnostic curettage. You'll do diagnostic curettage of endometrium, right, of uterus. You'll do diagnostic curettage of uterus. So this is the uterine cavity. Then you'll take out some part of the endometrium. So you'll do diagnostic curettage, right? You take out some part of the endometrium, and then you do pathological study. On the slide you can get some encephaloid matter. So the encephaloid matter, so they have mentioned this word encephaloid matter in the pathological finding. Okay, this is the pathological finding. So a patient, a post-menopausal female, was presented with a complaint of post-menopausal bleeding. Okay, and then you did diagnostic curettage of uterus, and in the pathological findings you are getting encephaloid matter. Encephaloid matter is because of hyperplasia, pathological hyperplasia of endometrium. Okay, then you can diagnose this patient as endometrial carcinoma. Endometrial carcinoma. Okay, so the cancer treatments, they never ask in the Krok. Okay, so they have never asked about the treatment of endometrial carcinoma or any gynecological cancer in Krok 2. Okay, staging they have asked. We'll quickly discuss about the staging of endometrial cancer. Okay, so there are 4 stages of endometrial cancer, and I'll try to simplify them for you. Okay, so in any cancer having distant metastasis, you call it endometrial cancer. You call it stage 4 of that cancer. Okay, so in case of any distant metastasis, that will be the stage 4. In case of endometrial carcinoma, stage 1 will be if the cancer is limited to endometrium or myometrium. So the cancer is limited to endometrium or myometrium. So it has not invaded serosa. Okay. In stage 2, the cancer has metastasized to cervix. In stage 3, there will be serosal involvement. There can be vaginal involvement, or there can be pelvic involvement. So I'll make a diagram for you so you can remember these stages well. Okay, so let's say this is uterus. Okay, and let's imagine this is the main primary focus of endometrial carcinoma. So there is a mass which is malignant. Okay, so this is the malignant mass, and we have done biopsy for this. This is find out to be a endometrial cancer. If this cancer, it invades myometrium, or even if this is limited to endometrium, okay, we call it stage 1. So this is stage 1. Okay, if this cancer part is metastasized to the cervix. Okay, we call it stage 2. If this is present at some other places, like it has involved serosa, invaded serosa, it is present in vagina, so mets are present in vagina, or mets are present in pelvis nearby, we call it stage 3. Stage 3. And if the mets are present at very distant places like in the lungs, in the brain, we call it stage 4 for distant metastasis. Okay, so if in endometrium or myometrium, we call it stage 1. If involvement of cervix, we call it stage 2. If involvement of serosa, we call it stage 3. Okay, involvement of serosa, involvement of vagina, involvement of pelvis. Okay, so in stage 3 there can be involvement of serosa, vagina, pelvis, and stage 4 is distant metastasis. So I hope like these stages can be easily remembered by this diagram. Okay, for cervical carcinoma they didn't ask many questions, but see, for endometrial cancer there was one thing which was very important, was postmenopausal bleeding. Postmenopausal bleeding, right? So you can suspect endometrial cancer in case of postmenopausal bleeding, right? For cervical cancer, the patient will complain of some contact bleeding. Okay, and on objective examination, you will see some mass. Okay, this mass can be like cauliflower mass on cervix. So you'll get to know that we are talking about cervical cancer. Okay, so this cervical cancer is, just remember this presence of cauliflower mass on cervix, and the patient will complain of contact bleeding. Okay, so for treatment, this we have to do conization of cervix, and before this we have to do staging. So staging of cervical cancer, I'm not explaining today because it will be very confusing. Okay, and they have never asked in Krok exam also. So the most important thing is how can you suspect we have got a question for cervical cancer is by getting these keywords like contact bleeding and this cauliflower mass on cervix. Okay, then we have completed these things. Let's cover these things also. There were many questions on premenstrual syndrome. Right. So there are many questions for premenstrual syndrome. So what is premenstrual syndrome is, there are some signs and symptoms which we get in female, so in reproductive age before menstrual bleed. Okay, before menstruation we get some signs in the female. Before means like there can like from 2 to 7 days. So if any female complaining of headache, okay, irritability, there's some nausea, vomiting, or mood swings. Okay, mood swings. There can be edema. There can be pain in breasts. There can be nausea, vomiting, vertigo can be there. Abdominal distension can be there. Okay, if any female complaining of these signs and symptoms 2 to 7 days before menstruations, okay, so she will tell you that I'm getting these symptoms like irritability, mood swings, and there's some breast pain, headache. Okay, and I usually get these symptoms 2 to 3 days before my menses, and the symptoms go away as menses start. start. Okay, so with this, by these symptoms, on these clinical symptoms, we can make the diagnosis of premenstrual syndrome. Premenstrual syndrome, like, so like pre means before menses we are getting these signs and symptoms. Okay, for treatment of premenstrual syndrome, if the symptoms are not so severe, okay, we can prescribe diet therapy, cognitive behavioral therapy. But if the symptoms are very troublesome for the female, so we can also prescribe COCPs, okay, combined oral contraceptive pills. Oral contraceptive pills for premenstrual. If these signs and symptoms appear just after menses, we call it postmenstrual syndrome. Okay, so these were about premenstrual and premenstrual and postmenstrual syndromes. Let's talk about menopausal syndrome. Postmenopausal syndrome. Okay, also known as climacteric syndrome. So in the Krok question, they usually mention climacteric syndrome, okay, for postmenopausal syndrome. So what are the signs and symptoms of postmenopausal syndrome? See, so there will be old age female around 45-50 years. We all know, like, there will be so the normal age for menopause is around 46, 47 or 51, so it varies from country to country. Okay, so just remember one thing is this. Let's say this is the life cycle of a female. Okay, so till 9 or 10 years, so this is the prepubertal female. Okay, so this is the prepubertal female. So there will be no sign and symptoms of menses. As the patient attains menarche, I told you for 4 to 5 years there will be an ovulatory cycle, irregular cycles, right? And then after some time, for long period of time, patient will have ovulatory regular cycles. But as the patient she moves towards her menopause, she will again get these anovulatory irregular cycles. Okay, so just remember this thing is, so as the female attains menarche, she will get 4 anovulatory irregular cycles for some time, let's say for 2 to 5 years of 2 to 5 years. Okay, after that there will be normal regular ovulatory cycles, and as she proceeds to her menopause, there will be again anovulatory irregular cycles. Okay, so in case of postmenopausal syndrome, there will be an old female around 45-50 years old, and she will complain of irregular menses. Okay, there can be some hot flashes, there will be headache. Okay, so all this hot flashes is the most important clinical complaint of the patient. Okay, then so she'll complain of irregular menses, hot flashes, headache. There can be increased of BP also. Okay, why? So irregular menses, okay, we have understood, because the cycles are anovulatory. But why do we get hot flashes and headache? Is because of increased FSH. Okay, there will be very high amount of FSH in the blood. Why this FSH is increased is, see, the main function for LH and FSH is for secretion of estrogen and progesterone. right? So as the female's ovary, they are getting old, so there will, so with age there will be decreased progesterone, there will be decreased estrogen, right? And they will have feedback for pituitary to release more FSH and LH, so there will be increased FSH and increased LH because there will be decreased negative feedback. So pituitary will try to increase more FSH and more LH to keep the progesterone and estrogen levels at a certain limit. Okay, so because of this increased FSH LH, patient will complain of headache and hot flashes. Right? Oh, there will be hot flashes. There can be insomnia also. Insomnia, sweat, increased sweats. Okay, so for treatment of postmenopause, we usually prescribe hormones. So we do hormone replacement therapy. So because all of these symptoms are because of increased FSH and decreased progesterone and estrogen. So if we will give progesterone and estrogen to the patient from outside, so the FSH level will decrease. Okay, and the patient symptoms will improve. So we will do hormone replacement therapy. Okay, so for the treatment of this postmenopausal syndrome, we are done. Okay, let's talk about infertility. So this will be our last topic for today. Infertility. Okay, so infertility, when we call infertility is, so there are no pregnancy even after 1 year of unprotected intercourse. So if the patient is unable to get pregnant even after 1 year of unprotected sex, we call it infertility. Okay, so patient will usually come to you complaining of not able to get pregnant. Okay, and when you ask her from how long she is sexually active, she'll tell you from 4 to 5 years we are trying to trying to get pregnant, but I'm unable. So we'll diagnose it. Okay, this is infertility. This is the case of infertility. And in any case of infertile couple, firstly you have to do semen analysis. Okay, so always just check the male first, because so it is possible that this couple is infertile because of there's some problem with male. Okay, but if there's normal semen analysis, now you can move on to female to check what can be the cause of infertility. So there are many causes for infertility in female. There can be PCOS. Okay, so for PCOS we have talked about, right? So if there will be infertility because of PCOS, in the question they'll specifically mention basal temperature is monophasic. I'll tell you here. In normal menstrual cycle, let's say this is the basal body temperature of the female. Okay, and whenever after ovulation, there's rise of body temperature by 0.2 to 0.4 degrees centigrade, and again then it comes back because of progesterone. This body temperature is raised. Okay, so this is biphasic basal body temperature, and this is seen in normal female with normal menstrual cycle. In case of PCOS, the cycle is anovulatory, right? So anovulatory cycle there will be no biphasic body temperature, so the body temperature of the female will be same during the complete cycle. So in case of PCOS we get a monophasic basal body temperature, right? What other can be the cause of infertility in female? There can be tubal causes. Tubal causes means, see, this is uterus and this is fallopian tube, right? If there's blockage, there's some blockage in fallopian tubes, so egg won't this ovum won't be able to come here. These semens, these sperms, okay, they won't be able to go inside, so there will be no zygote formation, so there will be no fertilization at all. So tubal causes are also there. Okay, so what increases these obstruction risks? Okay, so what can be the cause of this tubal infertility? So there's some previous infection. Previous infection means there can be history of salpingitis given. There can be some previous history of surgery given. History of some previous surgery can be given, so which might have caused these tubes to get blocked and there will be no fertilization. Okay, so apart from tubal causes and PCOS, what else can be there? Endometriosis. Endometriosis can cause infertility. Cushing syndrome can cause infertility. Hypothyroidism can cause infertility. So these are the main causes for infertility. Okay, yes, that's it. So today we have discussed about, so I'll just rapidly revise the complete thing. Okay, so in gynecology we talked about menarche, we talked about precocious puberty, we talked about early puberty, talked about delayed puberty, talked about juvenile bleeding, okay, also known as adolescent bleeding. Right, we talked about primary amenorrhea and we talked about secondary amenorrhea. In secondary amenorrhea we covered Sheehan syndrome. So there are many causes for secondary amenorrhea, and yesterday we talked about Sheehan syndrome, lactational amenorrhea. Okay, then prolactinoma. There can be Cushing syndrome. There can be hypothyroidism. There can be anorexia nervosa. Okay, then we talked about this PCOS separately, about endometriosis. I hope all of you remember about these things. Okay, PCOS. Okay, for endometriosis, just remember this keyword: chocolate color, vaginal discharge. There will be cyanotic eyes. Okay, these cyanotic eyes are the lesions of endometriosis, usually seen on laparoscopic or colposcopy. Understood? Then we talked about premenstrual syndrome, postmenopausal syndrome, okay, and about cancer, endometrial cancer and cervical cancer. Done. So guys, this I tried to cover all the topics of gynecology today. Okay, if there's some topics left, we can discuss in some later classes. Okay, in later sessions. Okay, thank you. Plus 806395. Mhm. And we can take all the doubts in the WhatsApp group. Okay, thank you.